PICC lines versus other central lines. Angela Hendley, RN BSN student, online at GSW. Instructor is McGee, April the 22nd, 2016. This is the presentation for my research paper. To reduce catheter-related bloodstream infections. The research paper seeks to answer the question, in adults aged 20 years and older, does having a PICC line compared to other types of central lines have less infection rate during the first 2 months? The opportunity to have a IV access, and with that comes the potential risk of infection. So you may need blood products, IV fluids, things of that nature, and they have found that if you're in the hospital, especially intensive care units for a length of time, that you're going to need a central line, whether that's a PICC line or some other type. And so because a lot of rates of infections have gone up with central venous catheter insertions, some organizations have a higher rate of infection with other forms of central lines versus the PICC line. Therefore, some organizations plan to reduce the amount of lines that are placed by doctors and increase the amount of PICC lines inserted by the PICC team nurses. Hospitals have decided to extend the PICC team as a method to reduce infection rates from central lines in their facility. Is there enough evidence that will support the increased use of PICC line insertions? The databases that were included in the study: PubMed and Biomed Central. The systematic electronic literature search included common databases up to February 2012. An extensive systematic electronic search was carried out on the relevant databases, including PubMed, Biomed Central, Google Scholar, etc. Due to the specificity of the review, various terms were included in the research to ensure that relevant studies were not missed. These terms included central venous catheter line, CVC, peripherally inserted central catheter, LIPORT, bloodstream infection, PICC infection rate, CVC infection rate. The selection criteria was English publications within the past 5 years. Articles that were considered suitable for inclusion discussed catheter-related CVC and or PICC bloodstream infection. Any article before the year 2011 was excluded. The study and the year, you have my 5 articles that I researched. The type of study is listed, the population size and age is listed, and the results. The first one was 2012, and ultimately the study found that PICCs were associated with fewer infections. The second study, 2012, said that their pooled data suggests the incidence that infections were lower in CVCs, but then another study indicated the opposite was true. So ultimately, the 2 catheter types do not differ with respect to catheter-related infection rates. Nolan, 2015. Ultimately, they said they identified only a single PICC infection in 400 central lines evaluated, making their MICU Pacific rates generally lower than those reported in other ICU settings. The fourth one, 2013. None of their studies were specifically related to evaluating infection complications, so they said there was no conclusions that could be made on the matter. The last one, 2012, there was not a single case of infections. PICCs presented 2.2 episodes per 1,000 catheter days versus 6 episodes in CVCs. So, in many studies that indicated over and over again that PICCs had a lower rate, and if you was trying to cut that rate in half, if you have 6 versus 2.2 episodes, if you was to cut that 6 CVCs and put PICCs in, you would be reducing that down to 3. So if most of the cases you had was 2.2, seems like this is a reasonable request to be made upon the hospitals across the nation. MMWR, Morbidity and Mortality Weekly Report 2005, acknowledged healthcare-associated infections in U.S. hospitals account for an estimated 2 million infections and 90,000 deaths annually. Central line-associated infections are the 3rd most common healthcare-associated infections. They also reported that CDC has identified catheter-associated adverse events, including BSIs, as one of its 7th healthcare safety challenges, with a goal to reduce such complications by 50% in 5 years. The change that will improve the incidence of lower central line infection rates in the hospital setting would be for the PICC team nurse to place as many central lines as possible versus the doctor. The PICC team is a small group of trained nurses that will place the PICC lines, change the dressings, and monitor for infection. The practice of using a smaller group of trained professionals to place the PICC lines will reduce the infection rate because there would be less individuals placing the central lines and therefore less possibility of infection. Following are the recommended guidelines that must be followed in order to reduce catheter-related bloodstream infections. The protocol to improve nursing practice and patient care. 1. The nurse must assess if the patient is in need of a central line and recommend to the doctor that the PICC team be consulted. PICC team personnel must be trained and exhibit competency in the insertion of catheters. Good hygiene before catheter insertion or maintenance. Maximum sterile barrier precautions such as the cap, mask, sterile gown, sterile gloves, and large sterile drape during the insertion of PICC lines. Preparation of central venous sites with 2% gluconate. 6 is the use of a biopatch at insertion site. This is a little small dome that when it's placed at the insertion site that it is supposed to be effective for 7 days to fight infection from entering through there. 7 is a transparent dressing. 8, a sutureless securement device. The facility that I work at has a stack lock that they use instead of sutures. 9, PICC catheters that are coated or impregnated with antiseptic agents. Use a PICC with the minimum number of ports or lumens essential for the management of the patient. There's a single, a double, and a triple that I'm aware of that we use at our facility. Replace the catheter site dressing when it becomes damp, loosened, or soiled. And that would be every 7 days. And then if it's a gauze dressing, it's recommended every 2 days. 12, do not routinely replace central venous catheters to prevent infection. And 13, remove any intravascular catheter as soon as it is no longer needed for patient care. This group at the top concluded the economic burden of infection is substantial. Estimated that each infection episode independently increases length of hospitalization from 7 to 21 days and adds an attributable cost of about $37,000. This was in the year 2002 per patient. The annual national cost of caring for patients who develop an infection is estimated to range from 0.67 cents to $2.68 billion. Given this clinical and economic cost, investigators, policymakers, and regulatory agencies in the U.S. and abroad have devoted great efforts to curtail CRBSI over the past decade, which is a central line infection. They also reported data from several studies suggests that CVC placement by specialized teams dedicated to this role leads not only to greater placement skills and reduced insertion complication, but also to reduce rates of institutional CRBSI, which is central line infections. The hospital, the insurance company, and the patient would benefit from the PICCs being inserted by the PICC team nurses, which would prevent infection, extra medical cost, and extended hospital length of stay. The CDC and the Joint Commission on Accreditation of Healthcare Organizations, JCAHO, would benefit when the rate of catheter-associated infections are reduced. The patient and the family would benefit greatly if the prevented infections were reduced or eliminated, reducing mortality. If you'll see at the bottom, I have the patient first, the hospital, the organization, so forth, and then at the end I have the patient again. Our utmost concern should always be the patient. The patient could be your loved one. The patient could be you. Now, in 2012, one of the studies I did argued that PICCs are also usually considered a device at low risk for catheter-related bloodstream infections, which may be an additional advantage in acutely ill patients. Also reported 4 significant findings. In a surgical ICU, PICCs presented 2.2 episodes of infection versus 6 episodes in other central lines. Number 2, even in a recent clinical study which reported a high incidence of PICC-related thrombosis, there was not one episode of infection in a cohort of 50 PICCs consecutively inserted in ICU patients. Number 3, in ICU patients, the occurrence of infection appears to happen later in PICCs compared with central venous catheters. So, if they appear to happen later with PICCs, if you can put the PICC in and as soon as the treatment is over, you can remove it, then there's a chance the person will never have an infection. But if you put in the central venous catheter, because in 13 days they're liable to have the infection already show up, that's definitely going to not help us with the reduction. And 4, in a burn unit, 37 PICCs had the incidence of PICC-related bloodstream infections was 0 episodes, as compared with 6.6 episodes of central venous catheter-related bloodstream infections for 1,000 catheter days. 4 more study arguments from the articles that we reviewed earlier. Pickwer and al. 2012 declared that their only comparative study found that PICCs 2.7% were associated with fewer infections than CVCs 4.9%. Nolan and al. 2015 found that only one single PICC infection in 400 central lines evaluated, making their MICU Pacific rates generally lower than those reported in other ICU settings. Johansson and al. 2013 reported a claim that PICCs had fewer complications of other kinds such as infections. Ugas and al. 2012 found that PICCs were associated with fewer CRBSI than CVCs in long-stay patients in surgical intensive care units. Evidence supports that the use of PICC lines versus other CVC lines reduce infection and reduce mortality rate. Therefore, the recommendation that more PICCs be inserted is favorable to become common practice in hospitals across the nation. I thank you for your time.